And you mentioned the pivot and shift test. Can you kind of explain what the test is doing and how it's performed? Because I remember for a while I knew, I knew it was, valgus, and I knew the technically how to do the exam, but I don't think I really understood what was actually happening in the knee until
Yeah,
recently. So can you kind of
sure.
go into what that exam is?
Yeah, this is something that always, and I remember this was like it's a gimme on the in training exam, and it actually is on your was on my board exam too.
Oh wow,
Um,
okay.
but it sounds like super complicated, and it's really not. Like if you practice doing a pivot shift exam a couple of times, and you just think about it while you're doing it in an ACL deficient knee, it becomes crystal clear. It's not something you can memorize. It's like riding a bike. But the way to remember it is if you don't have an ACL that's functioning in your knee, when the knee is in extension, the tibia will be subluxed anteriorly. So the starting point for a pivot shift exam is an abnormal tibio-femoral relationship where the tibia is too far anterior. And what you're doing essentially when you apply the various forces, and there are lots of different descriptions for exactly how to do this, but essentially if you load the joint in some capacity, so you apply like an axial load through the foot so that the joint's compressed. If you then go into flexion from an extended position, and again, there are variables about whether you apply valgus or internal rotation or you do it with in neutral rotation with varus or with abduction of the hip. All those things are like icing on the cake. The idea is that if the tibia is subluxed anteriorly when the knee is in full extension, and you bring the knee then into a flexed position, the the thinking is that the IT band and the lateral capsular structures then will reduce the knee into a reduced position at about 30 degrees of flexion. And what you're describing is the way in which that reduction occurs. So if it's not that sublux to begin with, when you do that maneuver, the tibia will sublux posteriorly or it'll reduce itself posteriorly in just a little bit of a glide. So it won't be that noticeable. You'll see a little bit of a shift. If it does it in like a more dramatic fashion, you say it was a true on shift, a 2+ pivot shift. And sometimes it can do like a full-on clunk where it's like almost dislocated, like the knee is almost completely dislocated, and it'll even get stuck or locked in that position. If it's a really high grade pivot where it just kind of when it reduces, it either doesn't reduce in a multi-leg. You'll see sometimes these a pivot shift, it'll be completely locked anteriorly, but if it clunks back significantly, that's a higher degree of laxity that you're assessing. So it's really just if you remember when the knee's in extension, which is how you start that exam, and you've got an ACL tear, if you're starting from a position of abnormal, and by then bringing the knee into flexion, you have reduction through the IT band of the joint, and you're seeing that shift of the tibia when you do it.
And that right there was a great explanation. I remember for a very long time, I could not explain that to you at all. I could tell you how to do it, but I could not explain that. And I think definitely understanding what you're doing and what's going on helps you, I guess, kind of be a little bit more keen to the actual physical exam findings and how to interpret that. So anybody listening that needs to replay that, please replay those last 2 minutes and listen to it again.